right. Welcome, everybody. We're going to do a live Q&A session. We have Dr. Drennan with us and Brett Lyle from Brett Lyle Consulting. And looking forward to questions from all of you out in our audience. So please go ahead and type them into the Q&A box, or if you're ready to be bold, click that raise hand icon and come up on the digital stage with us. But in either case, love to hear from you. So oftentimes these kind of blend together, the panel discussion and the Q&A. So I'm just going to continue along those lines as we wait for people to start entering some questions or comments, Dr. Drennan. One of the things we started talking about was looking at physiologic monitoring, and we didn't really get into feedback loops much, but that's kind of where I see this perhaps heading. And, you know, part of the purpose I see with the conference is, in addition to the EMS decision maker getting better informed about what they need to purchase and what they need to look for, I also want this to be bi-directional. And as I think we started setting some precedent here, is giving some feedback to the suppliers about the things that we would find useful. And with that in mind, the thing that has fascinated me is the possibility of creating feedback loops. So it's such that, let's suppose we're monitoring ventilation and we see a given end tidal CO2 signal. Could that potentially auto-adjust the ventilation? Because we started doing this a little bit in other aspects of resuscitation. I think it's mostly with pediatrics, where they recommend putting in an A-line and then titrating your compression depth to the physiologic signal. What potential do you think there is for doing that as our instrumentation here improves?
Yeah, that's a great point, Mick. Personally, I think what you see is that as we move towards technology that allows us to monitor individual patients, as opposed to just trying to make sure that we're meeting guideline requirements, I think what you're going to see is a little bit more of a movement towards providing patients exactly what they're looking for in the or exactly what they need during the resuscitation. So I use the example, it really comes down to whether we have the right measures that we're measuring and whether that's going to improve outcomes. So we have a lot of work to do, I think, on the science side of it, but we got a little bit into that conversation when we were talking about end tidal CO2 and near-infrared spectroscopy as well, where if you're measuring a physiological parameter, let's take end tidal CO2 because it's maybe the easier one to think about. But if you have an end tidal CO2 measurement, maybe there is a value where that end tidal CO2 is, would suggest that there is enough perfusion happening and that you just need to have a little bit more time with doing CPR in doing exactly what you're doing. But maybe there's an end tidal CO2 value that once it drops below, maybe that means that you need to either fix your CPR, or maybe that's the time when you need to start to give your resuscitation drugs. So, when you talk about art lines, there is some, body of research and some a system of thinking that that you should only be giving epinephrine when you don't have enough perfusion, which makes sense, right? As opposed to giving it every standard 4 minutes, which we do because we don't have any better way of measuring that. So, I think there's a lot of value in finding some feedback devices that can offer us feedback that will allow us to tailor our treatment and tweak the treatments that we're giving people during the resuscitation, and to provide our treatment on a more physiological based principles as opposed to just standardized guideline recommendations. It's really just a matter of whether we have the right tools and we have the right technology to do this, or whether there's something better that we should be using. So it gets a bit trickier in the pre-hospital setting because a lot of the stuff we do there has to be, non-invasive, has to be a little bit easier to use. So we have to be able to kind of correlate some of these measures to the more invasive measures. And I think that's kind of the stage that we're looking at right now.
Yeah, and this whole issue of non-invasive measurement is huge. I mean, because we don't want to overly complicate the case by, putting in art lines and floating in Swan-Ganz catheters and all of that, although now we're doing field ECMO and aortic balloons for hemorrhage control and a lot of things that we might not have thought feasible not too long ago.
Yep.
But that said, there's also other technologies that we already have, and it occurs to me that perhaps we're constrained a little bit by this is the way we've always done it. We have plasmography channels to mechanically measure perfusion. We have oximetry sensors, but we've tended to limit their use to the fingertip or the earlobe. What would be your thinking, Dr. Drennan, about whether or not those same sensors might be applied to more central sites, whether it's perhaps on the neck? I ran across some old literature back from the 50s or 60s with post hypopharyngeal sensor technologies, and it was looking at plasmography. So imagine you've got this balloon. It's back in the posterior pharynx, which is directly proximal to the carotids, and they were using the pulsatility on that balloon as an index of central circulation. And I thought, well, gee, if there was an oximetry sensor on there or other transcutaneous gas sensors, we might not lose the signal during resuscitation or shock state. So do you see any potential for that? And again, we're kind of putting on our dreaming hat here, but I think it kind of illustrates the notion that we have a lot of the basic building blocks here, but perhaps we just need to put our Legos together in a different configuration.
Yeah, no, I agree. I think that we do kind of get a little bit into that security blanket of just continuing to do things the way we've always done them, which it can make it a little bit hard to see that progress. I mean, the other side of me on the scientific side makes me think that science has to come first. So we do need some evidence behind some of this stuff. We see in a lot of different areas where we see more complicated measures, or people start to use more invasive tools assuming they're better, and then we end up backtracking when we realize that doing the extra complicated stuff sometimes doesn't actually add anything to your treatment or your resuscitation. But I think that years ago, and not even that long ago in EMS, that we were quite limited in our monitoring capabilities. But as the technology has really advanced. Sorry, so I got disconnected there. The technology has really advanced, which has allowed us to start to look at some of these more advanced ways of monitoring our resuscitation. That's why I was so intrigued by the NIRS stuff, because ultimately what we're trying to do is perfuse the brain when we're doing the resuscitation. And NIRS is it seemed to have some theoretical advantages, because it's measuring to some degree, it's measuring what we're trying to achieve, which is that brain perfusion. So it hasn't quite panned out as of yet in the literature, but it's still kind of early. So it'll be interesting to see where that goes. I see someone else in the chat there, Joseph, mentioned stuff like ultrasound and stuff too, which that again, more monitoring technology that we wouldn't have thought about a few years ago in the pre-hospital setting in terms of paramedic use of ultrasound. So I think we're going to see, as technology becomes more accessible pre-hospital, right? Like ultrasound used to be on the big portable in hospital machines before, you could have never brought into the field. But now that we have handheld devices and devices that hook up the size of a smartphone, it becomes much more attainable in the pre-hospital setting. So one of it's making sure that this technology works, and then the other is the pre-hospital side of it, which is, will it last to the rigors of working in these unpredictable and unsecured settings that we have to work in the back of an ambulance.
Yeah, absolutely. And it has to provide real clinical value, because we don't want to just measure something because we can. I think there has been a tendency to do that in many cases, particularly with EMS data in general. I see an awful lot of reports that, count how many IVs Bobby started last week, just because we can. It's not particularly actionable. But I think if we come back to the perspective as you were bringing in, what are we actually trying to accomplish? We're trying to get blood, well-oxygenated blood, flowing through the brain and other oxygen-sensitive tissues. And it's not just the brain. We want to make sure the kidneys are perfused. The nephrons certainly, have a very high rate of oxygen consumption, et cetera. And we want to avoid all of that. But As we've said time and time again, you can't measure we can't improve what you can't measure very accurately, and that's why I really see this appropriate emphasis being placed on monitoring what we're doing, because like we mentioned, we've known that ventilation has been important for a long time, but we didn't have a way to measure it. And so it just kind of was, well, we can't do anything about it anyway because we can't measure it. And that's why I'm maybe trying to, raise a flag here that I suggest that we have a lot of the technology with plasmography, capnography, oximetry, electrocardiography, electrical signals, if you will, to look at a whole lot more perhaps than what we're looking at that could give us a better picture, a more complete picture physiologically of what's going on, and then winnow that down and say, of all of these parameters, which are the ones that really are giving us the most juice for the squeeze, if you will.
Yeah, no, I think so too. I mean, I think that, this might be the time where we have to try a bunch of new ideas or, old ideas in new ways to see what works. And then we kind of follow where the science goes with that. I think the exciting part about this stuff to me, the resuscitation, technology moving forward, is that ability to monitor the patient at a more individual level. As we start to do that, I think what we see, which we've always known, is that every patient is a little bit different. And so what we start to see is that if you apply that standardized, this is where you should place your hands to do chest compressions, for a lot of people that might not be the optimal, just based on their physiology. So though I think the more we can measure in terms of new things, I think it'll help to improve the science. But I also agree with you that measuring the stuff we're currently doing, I think, is vital, right? We always, especially in EMS, we're always looking for the new, the new coolest technology, the latest gadget that we can add to our resuscitation. But, I think measuring what we're already doing, right? Like if we're thinking of adding, PEEP to your ventilations, and you want to grab that kind of PEEP monitor, but you're not measuring your CPR quality, which we know is impactful.
Yeah.
I think step one is measuring the stuff that we know works and making sure that you're doing what you think you're doing, which is, are you doing good chest compressions? How are your ventilations, right? I think not measuring our ventilations, like you said, it worries me a little bit, because I think, inherently we know we're not probably fantastic at it during that resuscitation. It takes a lot of focus and skill to really provide good ventilations during the entire resuscitation. And I think we're only starting to look at that piece now. And so I think it's really important that we have ways to measure what we're currently doing. And then also we'll start to, as we move forward, with resuscitation science, we'll find new ways to perhaps individualize that care a little bit more.
Yeah, and Joseph also brought up, I thought, an interesting idea with smart tubes that would be able to differentiate whether they're in the trachea or the esophagus based on electrical resistance of the tissues, which he points out is theoretical. But it really kind of highlights the point that there's a lot possible with existent technology, and it's really more of a configuration and application issue. But it always also raises the issue of cost, and I think that's a factor. And I think that this is where my interest in systems partially comes from. Is if the system of care is what's compensated, then we may find economically that spending that incremental amount for the smart tube or this additional sensor or this channel, in terms from an actuarial standpoint, has an economic benefit to society, to the at-risk insurer, to the premium payer, et cetera. We can figure out a way to align these incentives. But then Bill comes in. Bill Kuhn opines, well, we got to make sure that they're prepared to understand all this new information, and look at the steep climb that we had, just with 12 lead EKGs, how long it took to go from that idea before it became mainstream. And I think it was even a longer trajectory with waveform capnography. Now we're looking at, post cardiac arrest data analysis, which I think we're probably woefully behind on. We've got the software tools are out there, but I'm sure it's got to be frustrating for the suppliers that they've gone to all the effort to build these tools, and I have no idea what the number is on the percentage of cardiac arrests managed by advanced life support survivors with data-capable defibrillators that actually get an analysis by those agencies. I'd be afraid to know what that number was, but
there's a couple common themes that have come up, and one I want to just draw a parallel to the conversation this morning about education is that there's this interest in the individual and how do we treat, how do we cater to, how do we understand, and I think the underlying theme here is the curiosity and being willing to drive that change and challenge those processes. And it really does start, as Dr. Drennan, you've said, and we've been talking to the whole time, it starts with taking that subset population and doing the work and publishing the information that's found and making that public knowledge, even if it's just in our small subset in this industry of pre-hospital, to be able to deliver that message and having people that are championing the science and the methods behind why we do what we do is so important. And I think that's where you make sure you don't lose this from we're doing this cool thing in Toronto, Canada, to what are we doing in pre-hospital environments across the globe.
Indeed.
Yeah, no, absolutely. I think that's a great point too.
Yeah, and Bill makes the point that people have to be able to read the research, understand what it is.
Taking
I think
here, Bill.
Bill, he made it. Yeah, absolutely. Like, there's a couple great points I was just reading in the chat from him. I mean, and it goes back to we can create all the technology and we can say that this is the best science, but it comes down to the education of the frontline practitioners, right? And I mean, we don't want to overly unnecessarily complicate these because it is a challenging situation in calls that aren't often done for some people with limited resources. Like, there's lots of different things that go into this from a pre-hospital perspective. But then I loved your example, Mick, of the 12 leads, because it did take us a long time to get people feeling comfortable interpreting 12 leads. Now we're seeing the same challenge with trying to get people comfortable with looking at end-tidal CO2 values. So just because we can implement something, there's always that backlog, the backwork for education and getting people up to date on reading literature. And there's literature out there that there's, as we all know, there's all sorts of different qualities of literature out there. And
Right.
We have a challenge now with people picking up a paper and saying that we should be doing ultrasound because this paper showed that we should. And it's a case series of 3 people that isn't going to change practice, but it's about educating people enough to be able to read research and to bring forward research to help implement practice changes within their associations too.
Right, and that's the key. I think it's teaching people not necessarily, what's right or wrong, but giving them the tools to make that decision for themselves, their agency, their market, their region. Yeah. Is this right for us, right? Is this practice something? And as other people start, adopting those practices and those, clinical advances and see the successes, then we learn as an industry, how does it serve and who does it serve? And that really, I think, drives away from, to Bill's point in the chats, there's champions of poor science, as there is with champions of poor data and, of poor communication. I think the goal here is not to teach people to follow, but to teach them to, I think it was, to Bill's point also, to teach people how to critically think and to come to those decisions for themselves and their agencies, rather than blindly following the logic. I think, we hear it a lot, but it's called a practice of medicine for a reason. Things that were being done even 10 years ago, the AHA guidelines have since come back and said that's not the right practice. And actually we were probably, causing more harm than good, but everybody was on board, right? So they call it a practice.
Yep. No, and I think so too. And I mean, I think it makes it easier to move practice forward in the future. When you look to the future too, if we're teaching people that this is how practice changes, not just to, don't just change your practice, but understand why we're changing it. And then as, we're always going to be advancing. So I think once people understand the process of advancing practice and science, then it becomes easier to grasp as we move forward even further into the future.
Right.
Yeah. And I'm just going to close with the thought that part of this is also driven by the available treatment. Before thrombolytic therapy came on stage, there wasn't a whole lot of point in doing the pre-hospital 12-lead EKG because there wasn't a whole lot we could do about it. And we just kind of went through that same exercise with stroke. Now that we have a way to treat stroke, now there's more interest in identifying stroke. Now that we know a better way to treat large vessel obstruction stroke, now there's more interest in it, and that's driving the technology to monitor these sorts of things. So interesting watching how innovation happens and how there's this intermingling of monitoring technology and treatment technology and education to get us where we want to be. So great conversation, everybody. We're going to go ahead and wrap up this session and conclude the academic portion, if you will, of the conference. And we're going to let everybody kind of hang out in the lounge for a little bit. Go ahead and visit the sponsors. And just a big shout out to the sponsors again, to Zoll Medical, to Stryker, and to RQI Partners for making all of this possible. So thank you to all of them. And thanks to all of you. I'll see you in the lounge. Thank you much.
Thanks.